This was touched with some I came to
Okay. Okay, let's get started. Let me have your attention. Welcome to the University of Tennessee Nuclear Engineering Department Seminar Series. Our speaker today is Dr. Gary Smith, who is Professor of Radiology and Medicine and Director of the Division of Nuclear Medicine, Department of Radiology at the University of Tennessee Medical Center. Gary is a graduate of the UT College. He's a graduate of the UT College of Engineering. He received BS in Engineering Science in 1978. Then he went to medical school at the other UT, the University of Texas, the one that has the wrong color of orange, right?
That's right.
He graduated there in 1983, and then he came back to UT, to hear our UT, and he's been here ever since, except for 1 year he did a residency in nuclear medicine at UCLA. His topic today is concepts in medical imaging, and we're indeed privileged to have you come and join us. Thank you.
Thank you, Lee. Appreciate everybody coming. Hopefully this will be a nice overview of some of the medical imaging applications. As Lee said, I'm the Director of Nuclear Medicine over at UT, but I didn't want to just limit my discussion to nuclear imaging, although that'll be the prime focus toward the end of the talk. But I thought what we'd do is kind of start with you may have to put up with me learning how to use the mouse. Kind of start with an overview of the electromagnetic spectrum and see what imaging applications have been applied across this spectrum for medical purposes. And many of the things that I'm going to be talking about were developed for other fields first and only came to light in medicine late. We tend to follow the other sciences in the medical field oftentimes. So we'll kind of progress, starting at the low energy portion of the spectrum, and move up the energy chain here. And you can see here kind of an overview. Radio waves give us MRI, infrared for thermography, visible light photography, and photodynamic diagnosis and therapy, which we'll talk about. Ultraviolet. Well, we haven't figured out anything for ultraviolet in medicine yet, other than treatment for certain skin disorders. So maybe someone in the audience here will figure out how we can use ultraviolet imaging for medical applications. X-ray CT, X-rays for X-rays and X-ray CT, and then gamma imaging for nuclear medicine and PET imaging. So that's the overall discussion, and please, at any time, I welcome questions and any discussion. But let's look at MRI first. Magnetic resonance imaging used to be called nuclear magnetic resonance, but historically the nuclear was dropped because of some of the social issues, the social implications associated with the word nuclear. As a matter of fact, some hospitals were being protested for installing nuclear reactors when in fact they were installing nuclear magnetic resonance imaging systems back in the early 80s. And so it switched to becoming known as just MRI. And now it's so commonly used. If any of you were at the UT basketball game the other day when Ron Slay hurt his knee, immediately the press was talking about that he was going to have his MRI scan of his knee that next day and try to figure out what had happened to him. So it's a well-known term. MRI, basically, in the way that it's used in medical imaging, highlights protons, and areas of high proton density show up typically bright, and areas of low proton density show up typically dim. Although there are many, many sequences that can be used with MRI to reverse exactly what I just said. So the areas of high proton density show up dim and low proton density show up bright. There are many applications in MRI, and I want to show you a couple of these. Here's Ron Slay's knee. Actually, this is a knee that was done about 20 years ago, so I don't think it could be could be his. But you can see this is a coronal section looking at the side of the knee. This is the lower end of the femur where it touches on top of the tibia here, and you can get nice definition of the muscles, the fat, the capsule around the bones and the bones themselves. Very nice soft tissue definition. But some of the new work that's being done in MRI is very interesting in terms of being able to highlight the vasculature. When we typically think about angiography, we think about inserting a tube into the artery, injecting dye into the artery, and taking a picture of the tree of blood vessels based on the distribution of the dye. Well, this image is done without any contrast agent whatsoever being put in. It's based simply on what was interesting. He was very familiar with this, but not with PET, and so he didn't associate that the two are very similar, very analogous in many respects. So this photodynamic diagnosis and therapy has been used really for GI tract tumors and for skin cancers, but it's also now being used in the eye, where we can visualize the eye and treat the diseases of the eye directly because of the accessibility to light rays. Now, the other thing, fluorescent microscopy is another area that's very much of interest in medical imaging, and the reason is because of the Human Genome Project. And I'm going to talk a little bit more about that in a few minutes. But the Human Genome Project has really spurred a lot of development in being able to identify specific areas in the cells, in specific cells that are activated. And these systems that allow fluorescent microscopy, this one built by PerkinElmer, and this image here from PerkinElmer, unfortunately I can't load the movie of this, but if you go to the PerkinElmer website, you can see the movie on this particular from this particular slide. And basically what you can identify here is you can see all of these green fluorescent dots moving in the cells and moving between cells, and so we can identify where specific proteins that are being created in cells are being shared between other cells and other components of the same cell. And we're really getting a handle now on the function of different tissues, function of different proteins in the body. And so you'll hear the term functional genomics being developed, so that we're not just identifying the structure of the genes, but now we're beginning to realize how they work. And this type of microscopy is really leading to insight. The latest one that I saw was in the journal Science, where now a fluorescent adenovirus that's used for viral therapy, actually transfecting a human cell with a new gene to treat a disease, have actually been able to, using fluorescent microscopy, track that viral entry into the cell nucleus in real time. And that's a first, so you can identify that those genes are getting into the cell and being expressed in the cell. And that's a new field of medicine that I think will develop in the next 10 years. Let's move on to ultraviolet light. Ultraviolet imaging, again, we use UV rays for treatment in psoriasis and other skin disorders, but we don't really have an imaging system. I looked and tried to find and wasn't aware of any. If any of you are aware of ultraviolet being used for imaging in medicine, let me know, because it's the one area of the spectrum that I have no knowledge that is being used for any type of imaging capability. And it may be because it's kind of living right between the visible light and the X-ray, where it's surrounded by a very useful application, but UV may not have a specific application, and I'll leave that up to you. So that moves on to X-ray and X-ray CT scanning. X-ray was discovered just over 100 years ago by Röntgen in 1895, and this was a picture of the first radiograph, a little bit squashed on this screen, of it's either his hand or his wife's hand with the wedding ring, and demonstrated that X-rays penetrate through the tissue and can be detected on an X-ray film or a film screen system. shortly after this, a gentleman developed what he called in-ray imaging, and he was the only one who could see the in-rays. And he had a big fancy apparatus to be able to detect in-rays. And he finally convinced a group of scientists to come to a room like this and turned out all the lights, put this device on the table, was detecting all of these films, and when they turned the lights on, a group of scientists had come and removed his instrument without him knowing it in this dark room, and he was exposed as a fraud. But X-rays remained as real. So this is an area that is really most used in medicine, as all of you know, for dental work and general radiography. But this is kind of a prototype X-ray showing different structures, the different densities that you can see of the tissues, basically proportional to mass of the tissue or density of the tissue, going all the way from metal to bone to water tissue, which would be down here, to fat tissue. You can barely see some skin fat up here, and then to air around the body and in the lungs. Does anyone know what this is? What's that? Pacemaker? Yeah, this is a pacemaker, and that's implanted under the skin of the chest here with the wire that goes down into the heart to pace the heart here. Well, those 5 densities, and we used to tease that it was air, fat, water, bone, and bullet. Those were the 5 densities that we saw when I was in training in Dallas, but now we see pacemakers instead of bullets. But these 5 densities are really about all you can see on an X-ray. So the concept of being able to increase the contrast on an X-ray came about, and X-ray computed tomography was born as a result of trying to improve image contrast. And tomographic imaging was first proposed back in 1917, just about 20 years after the X-rays were discovered. And over the next 50 years, up until the mid-60s, various attempts were made to create a tomographic system for X-ray imaging. But it really took until the early 70s, late 60s, early 70s, before we could develop an X-ray CT system. And they began being installed in hospitals in the late 70s. Do you have any idea why it took so long to create these machines?
Maybe computer.
You needed the computer. That's right. You can't do this type of imaging without the computer, and so it really required a number of devices were devised for analog CT scanners all through the 30s and 40s, but analog systems fail, and I use the analogy of the Hubble telescope spherical aberration. All analog systems fail because they have the equivalent of spherical aberration built in, and you have to have the digital system to get rid of that. So, and I may be able to show that in the next few slides. But in 1973, Hounsfield developed the first clinical CT scanner, and he went on, and 6 years later, 1979, won the Nobel Prize for Medicine. And it's a well-deserved Nobel Prize. It's one of the few Nobel Prizes in medicine given for imaging, but it's revolutionized our ability to to diagnose and treat disease. The CT scanner, in some respects, and I tease about this, and better be careful about who's listening on the web, but in some respects, the CT scanner has replaced the physical exam for diagnosis. But it's truly revolutionized medicine. Are any of you familiar with EMI Incorporated, the company that built the first CT scanner? You're shaking your head, yes. It's housed in London, England.
It's a record.
The record company, that's right. And their research and development division is who Hounsfield worked for and actually developed the first CT scanner. So
So one of the computers is the Beatles, right?
It's the Beatles that actually did it for them. That's right. Well, Hounsfield shared the Nobel Prize with Alan Cormack, who figured out the mathematics of digital image reconstruction and figured out how to get rid of the aberration, what I call the spherical aberration artifact, or the blurring artifact. But it turns out they weren't the first ones to develop tomographic imaging. Radon proposed it, but Bracewell in 1959 really invented radio astronomy tomography, and the concept of tomography from Bracewell's work, looking back, is what we use today. And this is the principle. To acquire X-ray transmission through an object, and my ellipse here with a green spot is the body with a tumor in it, and to acquire many different X-ray transmissions through that object in many different angles to create these profiles, these X-ray intensity profiles. And then to use those profiles, I'm sorry, I'll come back to that, but this is one of my favorite movies, Contact, and I use it because this array of telescope antennas back here creating a tomographic, potentially a tomographic view of the skies, using the same concept of many X-ray beams through the body. It's receiving many X-ray signals in parallel from space. But you can see tomography has been used in many different fields of science, and I'll show you a few pictures here. This is from electron microscopy. This is actually a 3D structure that can be rotated. If you look at it, it can be rotated in 3 dimensions, showing the DNA histone proteins around the DNA helix. This is a slice through the ocean showing the sound speed through the ocean, which is actually a function of the temperature of the water. So you can actually get a cross-sectional cut through the ocean of the speed of the currents and the temperature of the water used in oceanography. And the way that this all works is to take what radon proposed here is the radon transform, showing an object in space, and that object in space is completely defined by all the projections around it. And then it's possible to figure out then, based on what we detect, what the original distribution of the object is. And one of the techniques used is filtered back projection. It's a simple technique, and I'll show it here, where all of those projections that I showed that were acquired, we now want to know what the object was to start with. And we acquired this data, but I don't know what's actually inside. So how do I figure it out? And one way is to back project each projection here on a grid. And for every projection that we acquire, you can see that these grids are going to overlap in the center. And that center point is gradually going to get brighter and brighter and brighter until, if I do an infinite number of these back projections, I create a bright spot in the middle, which kind of mimics my original spot out here inside the body. The problem is that I have all of these stripes here that weren't in the original object. And if you build an analog system, you can't get rid of those stripes. But a digital system, you can do some filtering of the image and try to get rid of those stripes. And that's the concept of what we do today. Here's another example of simple back projection in an object with 2 spots, where we have each projection being back projected with 1 angle, 2 angles, 4 angles, and you gradually get closer and closer to the original object, but there's a lot of blurring around the outside. And that's that spherical aberration that I'm talking about. And it's analogous to the Hubble telescope images prior to the COSTAR correction optics being put in. So what we do is filter this, so we change the projection and create what's called a filtered projection based on Fourier techniques. And you can see there's small negatives built in to the filtered projection, so that when you back project it, those negatives tend to cancel out the adjacent projections. And gradually, as you do more and more of these, you cancel out, and what you're left with is much more similar to your original object. And that's the concept of filtered back projection. It's the technique that we use for MRI, for CT, for SPECT imaging, and PET imaging today. Now, there are a lot of other new imaging techniques being developed, but this is what we use today for image reconstruction. And here's an example of filtered back projection with many angles, again, 32 angles at the bottom, and most of that blurring is now gone. And this reconstruction more closely mimics the original than what our non-filtered back projection did. So, a couple of years ago, a student in one of the nuclear engineering classes asked me how to generate a cross-sectional image through a pipe from a plant out in Oak Ridge using an X-ray through the pipe and looking at many angles. And we developed this back projection process and he created cross-sectional images. It's the same process. So here's an example with a little bit more clean data as you gradually increase the number of projections. This application actually came from a high school student who did this as part of a science project using an Excel worksheet. So it can be done without the high-speed computers that we use. Well, how do we use this? In X-ray CT, remember we had the five densities on a regular X-ray. Well, with CT scan, each of these pixels in the image, this image is 512 pixels across and 512 pixels down, and each one of those pixels can be resolved to within about 3 decimal places in terms of the tissue density. And that's a pretty remarkable amount. It gives us about 2,000 levels of gray that we can image these, or 2,000 separate contrast values that we can image in CT now, as opposed to the original 5 that we started with plain X-ray. And again, the more dense the tissue is, the brighter it is. So the bone here is very bright. You can see a cataract in his eye. It's very bright because it's very dense. And the tissue around the eye is more dense than the muscle. This is the optic nerve controlling the eye. And these are the muscles controlling the eye movement. And in this particular case, there's kind of a dark spot here indicating an infarction in the central nervous system. This bright spot here is part of the bone. It's not a tumor itself. This is just a little bit crooked on the table. Here's another example showing a cross-section through the head at 4 different levels. And the bright area here is blood that has leaked out of the bloodstream. And this is an aneurysm with actually some bleeding around the aneurysm. And here's a case of a cross-section through the chest. Again, you can see fat tissue here, the muscle density, the bone, and this is lung tissue in here on the left side. Radiologists have the rights and lefts mixed up, so this is the left side over here. And this is the right side, and you can see all of this tissue in the chest that's not on the other side. Well, the lung should be fairly symmetric. There shouldn't be a whole lot on the left side or on the right side that's not on the left. And so this is actually all tumor tissue in the chest. A big lung cancer. A reminder not to smoke. Everyone quit smoking if you do, and don't start if you don't. So. Well, let's look at gamma imaging. The final point on the spectrum, the highest energy. Nuclear imaging technology, I already explained it to you with photodynamic diagnosis. We start with a radioactive material instead of a light-sensitive material. And in typical, in nuclear imaging, we use generators to create the radioactive tracer. But for PET imaging, we use cyclotrons, and some places still use accelerators to generate isotopes that they then ship to us in small vials. For example, indium-111 we use every day in nuclear medicine, and we have to buy that from distributors who get it straight from reactor facilities. But the isotopes are typically obtained from a generator. Those isotopes are then chelated chemically to a chemical compound that is specific for a given tissue. If we want to look at the heart, we use a material that binds to the heart muscle. If we want to look at the brain, we use a chemical compound that binds to the brain, and it's chemically adhered. We take advantage of the different body chemistries of the different tissues in order to do this. So the radioactive tracer is chelated to the material, and then what we end up with is, by combining these two, we end up with a radioactive tag on that material. This particular compound, called MyoView, is an imaging agent for the heart. And if you look closely on this, here's a little time clock. It only takes 15 minutes to constitute this material. So we can have it available literally on demand if somebody comes in with a heart attack and they need one of these scans to be done. We can have the material ready in 15 minutes. It's then injected into the body and goes to the tissues based on its chemistry, and then it's imaged with a gamma camera. And the final product then is, in this case, a cross-sectional view of the heart itself. And I'll just tell you, in this particular image, the top row of pictures is looking at the heart from the very bottom up toward the top. And you can see, and this is at rest. So the top row goes from the bottom all the way up. And it's kind of like cutting through a football. If you start at the point of the football and start cutting through, it should grow into a bunch of donuts, right? And that's what we have here on the top row. But on the bottom row, you start at the point and come up, and there's this large kind of bite taken out of the bottom part. And this is an area that, under stress, is not getting as much blood flow as it's getting under resting conditions. And that's an area where there's an artery block there, and that's going to have to be opened up surgically or with a balloon angioplasty. And this occurs also because of smoking, so don't smoke if you don't start. But this is kind of what the images look like from nuclear imaging. The instrumentation is either planar or tomographic, using a planar camera that circles around the body and takes these images from many different angles. And it's standard detectors like you use in nuclear engineering, with sodium iodide crystals and electronics that localize the position of the events within the body. And so we get tomographic, either a planar view or tomographic cuts through the body. In this case, a bone scan showing nice detail of the ribs, the spine. How about these things? Very tough to see. Anyone want to guess what those are? The kidneys? Yeah. Why would we see the kidneys on a bone scan? That'd be one reason. If there was calcium deposition in the kidneys, you could see it, and that does happen from time to time. But actually, it's because all the excess material is eliminated through the kidneys. If it doesn't get in the bone, it's eliminated through the kidneys, and so we see the kidneys show up on these scans. And then we can take cross-sectional views, and you can see actually each one of these is not a whole through-and-through image, it's just a slice through that spot. Positron tomography works the same way, it's just that the isotope is different than in SPECT imaging or single photon emission computed tomography. And in positron tomography, we detect both photons coming out of the body with two coincident detectors. And the real advantage of PET imaging is that we can create F-18 analogs or carbon-11 analogs or other analogs that are more biologically active than we can with general nuclear tracers like technetium and indium and gallium and so forth. So it becomes a process of functional imaging, going from the true look of the tissue to the CAT scan, an MRI scan, and now a nuclear medicine PET scan what's the difference in this patient and all of these patients? Say it again? He's alive. That's right. You can't get a nuclear medicine picture of the brain showing the brain functioning, either glucose metabolism or blood flow in the brain, unless that brain is actually living. But all of these pictures were taken from a cadaver, and you can't really tell the difference between them and a normal CAT scan or MRI scan. The nuclear imaging gives us functional images of living tissue, whereas the others give pictures of the anatomy, living or dead. Again, it's not 100%, but it's close. So, in PET technology, we create this isotope from a cyclotron typically, and we can create from these isotopes many different agents that are biologically active. The problem is the half-lives. Oxygen 15, if we want to inject water, radioactive water with O15, just to see where the water distribution or the blood flow is in the body, it's a 2-minute half-life. And as a rule of thumb, 5 half-lives is gone. So in 10 minutes, we have to produce the material, quality control test it, inject it, and image it, or it's gone. So it's, the place is a busy place when we use O15 water. But our mainstay is fluorine-18. We use fluorodeoxyglucose in almost every patient now, and that's a sugar analog. It's got a 2-hour half-life. So we can make it and keep it around all day, but tomorrow we have to make it again. And this is ordinary glucose. If we replace this hydroxyl group with a fluorine, that's FDG. And what it does is it parallels glucose metabolism in the cell, but it can't be metabolized after it gets phosphorylated. So it goes from the bloodstream into the tissue, sticks there, similar to that chlorophyll analog that I showed you earlier, the photocrin. And this material sticks in the tissue, and so you get those pictures of the brain with the material distributed throughout wherever the glucose is being used. You see the FDG also being used. And we can quantify this material, and I'm going to show you an example of determining the glucose consumption by the brain, but we can also quantify blood flow in the heart, we can quantify neurological receptors in the body, and all of this work is being done at various centers around the country and around the world. Let me just give you a quick overview of how this might work. If we want to quantify the activity inside this region of interest here in the striatum, we can plot over time how much material is being taken up. And so the plot over time might look like this, where the activity level is shown here as a function of time. And by looking at that previous slide of the model of how FDG is distributed in the body, we can develop a system of differential equations that defines how the shape of this curve should look for a given metabolic rate. Using this model, we can define a system of equations that define this metabolic rate of glucose based on these rate constants. And here's the equation. So if we can estimate K1, K2, and K3, we can calculate the metabolic rate. And here's an example where the first guess of K1, K2, and K3 overestimated the curve, the actual data shown in yellow, and our mathematical estimate shown as a solid line. So we re-guess these rate constants using a systematic way. There are many ways to do this. I think several of you in here have been involved with how we might do this. But in a systematic way, we might re-guess these rate constants, and now we guess too low. And if we guess a third time, we guess right on the line. And by plugging in these values of the K values into this equation, knowing the blood glucose concentration, and knowing this is a constant value for brain tissue called the lump constant, we come out with a metabolic rate of glucose of about 8 milligrams per minute per deciliter. So we can actually quantify how much glucose that brain tissue is using. That's one advantage of STEP. And how's that used? Well, here's a graph of metabolic rate of glucose as a function of age. And you can see a newborn has a rate of about 20 micromoles per minute per 100 grams. By the time you're about 5 to 10 years old, you peak out how much glucose your brain is using. And by the time you're a young adult, you've pretty much used it all up. You've used your peak. It's all downhill from about age 10. So this is work that's been done on kids with seizure disorders, but it's interesting to see that the normal glucose utilization in the brain peaks out about age 10 and decreases thereafter through adulthood. So don't give kids too much sugar, I guess. Well, how do we use it clinically? Again, brain, cancer imaging, and heart imaging. All of these spots in this whole body picture are tumor spots in the body, metastatic tumor spots in the body. So let's look real quickly at a couple of applications. This is a look at dementia, Alzheimer's disease, Parkinson's disease lead to potential dementias, Alzheimer's, of course, by definition. And what we see in a normal brain is normal glucose uptake, but in a patient with dementia, you can see the posterior part of the brain here is almost missing. And in a patient with Parkinson's disease, the caudate nuclei, which should be here, and you see that on this scan with fluorodopa, is missing. So using these different tracers, we can characterize different disease states, which is important. In the past, we've pretty much had to rely on clinical diagnosis, and it may be that half the time we're wrong clinically differentiating Alzheimer's dementia from Parkinson's dementia. We may not realize what the actual disease is, and if we try a therapy for Parkinson's and they actually have Alzheimer's, it may not work. So we can monitor therapy. So all of these ways of imaging the body and the body systems gives us a new approach to monitoring therapy as well. Here's a brain tumor showing glucose utilization. The next day this patient had an amino acid scan. You wouldn't be able to see the tumor here on the glucose, but you can see it well in the amino acid scan. So this is an idea showing that different tracers may give different impressions of the actual diseases. 3 different patients, another patient, again showing tumor with the amino acid, and a third patient, you can actually see the tumor here on the glucose, but not nearly as well as here. And this is research that we're doing at UT right now on the amino acid tracers for brain tumors. In cardiology, we're primarily interested in whether the heart is alive or dead. As I mentioned, the nuclear tracers can tell whether the tissue is alive or dead. And in this particular patient with a hole in their heart on blood flow, you might wonder whether it's alive or dead. Well, here's the glucose picture. What's the answer? It's alive. It's definitely alive, and this patient would benefit very well from having their vessel reopened. They would regain function of that part of the tissue and would have a very good outcome. We can predict very high accuracy who will have a good outcome from bypass surgery. Yes.
In that second image of metabolism, why does the rest of the heart not also have high metabolism?
Well, in this particular case, this area of the heart is actually ischemic. And in ischemia, what's called anaerobic glycolysis kicks in. There's a lot of glucose utilization in the area that has very little oxygen supply. The rest of the heart is receiving oxygen because it has good blood supply. It's not using sugar, it's using fatty acids, which is the heart's preferential fuel. The heart only uses sugar if it's forced to. And in this case, with ischemia, it doesn't have fatty acid, requires oxygen. So since it can't use fatty acid, it uses sugar. So that's what this is. Good question. How about oncology or cancer This is a couple examples. This particular individual had a CT scan that showed 2 spots in the liver, had a prior history of colon cancer, and we know that colon cancer tends to go to the liver when it spreads. And this individual had 2 spots in the liver on October 3rd, and a month later, with no treatment, those spots had disappeared. This individual did not want treatment, did not want any therapy. They went home, came back a month later, and they're all better. It's a miracle. It actually looked great, but we did a PET scan, and they're still there. Anatomically, they were difficult to see the second time. We did a third CT scan with a better contrast agent, and indeed they were still there. So the PET scan showed that those tumors, and actually there was a third one that wasn't seen on the CT, those tumors were still there. This is kidney, and a bladder here. This is an individual who had a thyroid scan in May of '98, had 5, actually this is 2 separate spots here in the neck, had 5 metastases from thyroid cancer. And surgically we could find 3 of them. And when he came back 5 months later after surgery, he only had 2 spots left. But now he has a new one up here. And when he came back, again, about 6 months later after another surgery, the surgeon was able to find the 4th one, but this one's getting bigger. So this is a way, again, we can monitor therapy, and if we could figure out how to visualize these things in the operating room, the surgeon could find all these spots the first try. But the surgeon doesn't have the benefit of the scan in real time in the operating room, and he's having to fish around and look, and they're very difficult to find. So we're talking now about developing one of these machines specifically for the operating room. Again, it's going to require some engineering. And here's a scan as late as this year, or late last year, showing that spot in the neck had grown even bigger. But the surgeon was able to get all of the spots further down. So he ended up having 4 surgeries for this disease, and he still has a problem with it. Another view of it, just in a different cross-section. And lung cancer, a spot seen on CT scan. We see a lot of spots in the lungs on CT and not all tumors. The question is this cancer or not cancer? And with the PET scan, we can definitely say that that's cancer. Not much question about it. And here's a whole body scan showing Hodgkin's lymphoma before chemotherapy and after chemotherapy. All of these tumor spots here have disappeared. So we can monitor the therapy. This is the most common cancer in young adults, ages about 15 to 30. So this is a way that we can monitor therapy. So what's the future? And I'll try to hurry this. I know I'm running a little bit late. The future is to look at antibody imaging and genomic imaging. I'm going to show you very quickly a number of antibodies have been developed for antibody imaging of tissues. And the concept is to bind a radioactive tracer to an antibody molecule which specifically binds to ligands on the cell surfaces or in the cells. And if we can develop specific antibodies for specific things, we might be able to get images directed. For example, prostate cancer tends to spread to regional lymph nodes. We do a CT scan and can't see any metastatic lymph nodes, but there may still be tumor cells in those nodes. If we can develop an antibody to go directly to those tumor cells and light them up, we can image that. We can image those. And that's the concept of these antibodies. And this is an example of the prostate cancer antibody material showing these lymph nodes in the abdomen and one in the chest. Normal liver uptake is a problem because it hides anything that might be in the liver. But all of these lymph nodes are abnormal, showing that the prostate cancer has spread beyond the prostate into the lymph nodes of the abdomen and chest. And there are a number of these antibodies that have been developed and many more in clinical trials today. And the last one is genomic imaging. And for this, we're beginning to rely on small animal models, mouse models, rabbit, and small primate, to define genetic, to be able to image genetic, functional genes in the body in real time. And this company, Concord Microsystems, here in Knoxville, is making scanners of all different sizes to be able to image. This one's a mouse scanner. This is sitting on the tabletop here, and we can actually image and cross-section a mouse with sub-millimeter resolution on these scans. And this is a cross-section of a rat heart with a small scanner. This is a whole body scan of the rat. And here's the human heart with a human scanner. So that the imaging resolution is analogous on the small animal as it is with the human. So now we can begin to test therapies on small animals and look at new drugs in small animal models to see if they're working without having to chop these animals up to see where the drugs are getting. And here's an example, one image, a rat in a whole body section of a rat showing one tumor that expresses dopamine receptors, and a few hours later, the same rat, another tumor expressing thymidine kinase gene function that's actually been transfected into that animal. So two different tumors in the same animal imaged the same day, showing different genetic characteristics. So we can begin to plan therapy to attack that genetic characteristic of the tumors. And this is leading to an entire new field of drug discovery in the pharmaceutical companies around the country. Virtually all the major pharmaceutical companies in the country are now looking at the possibility of the small animal PET imaging to help formulate new drug therapies for the companies. So we've gone through this whole spectrum of imaging from radio waves all the way to gamma rays, looking at MRI, thermal imaging, photodynamic therapy and diagnosis. I'll leave ultraviolet to you. X-ray CT scanning, and SPECT and PET scanning in the nuclear side. Thank you.
Okay, we have time for maybe one or two questions. I have a question. What percentage of your time do you spend in clinical practice versus doing research?
I spend about 50% of my time in clinical practice, and it seems like the other 50% just keeping things running sometimes. But probably I would say about 20% of my time in research, about a day a week.
Any other questions?
And we try to get, I think most of the students that we've had come through our laboratory, quite frankly, have been through engineering, computer science. We do have a chemist, Dr. Kabalka, who works with us, and he's had quite a few students come through. But in my section, they've been predominantly engineering and computer science students. So it's a broad field. It's not just residents rotating through.
I noticed that we have lots of visitors today, and the visitors probably don't know, but we always adjourn downstairs on the second floor for refreshments after our seminars, and we do have refreshments today, and all of you invited. But before we adjourn, let's express our appreciation to Dr. Smith one more time.
Thank you.